Kia ora koutou, ngā mihi nui ki a koutou, nā mai haere mai ki tēnei hui, ki tēnei wānanga. Ko Ngāti Kahanunu, Ngāti Poroko iwi, ko Tristram Ingham ahau. Tēnā koutou, tēnā tātou katoa.
Kia ora anō tātou, ko Tararua te maunga, ko Waikawa te awa, ko Ngāti Raukawa te iwi, ko Ngāti Wihiwihi te hapu, ko Cheryl Davies ahau. Ka nui te mihi ki a koutou I tēnei hui ngā whakahirahira. Tēnā tātou katoa.
Kia ora, and it's our great pleasure to have this opportunity to touch base with you again. For those you were here last year, we heard the results of phase 1 of this Māori Engagement strategy, so it's a great privilege to be able to be back here and update you with what we've been working on. Just to remind you, the Asthma Foundation's vision being better respiratory health for all New Zealanders, we've got a really lofty goal, one that I have to say we're not yet achieving, and that is to reduce respiratory hospitalisations by 25% by 2025. We have a lot of work to do to get to that goal. And you've seen today the introduction of what we hope will be our roadmap to get to that goal. If you've seen in there, you'll see we've got some terrible statistics. 700,000 individuals living with respiratory disease, costing us over $5.5 billion per annum in direct and indirect costs. Lung disease is the third highest cause of disability. We're talking about 100,000 disability-adjusted life years lost per annum. And it's the third highest cause of hospitalisations in New Zealand. These are terrible statistics. And what's even more shocking is the lack of systemic response to these. For those who heard me speak last night, I said that inequities in respiratory are pervasive. And I think this graph really sums that up. These are the standardised relative rates of hospitalisations for respiratory conditions. So the green bars represent Māori admissions, the blue bars, the rest of the population. You see we have between 2 and 5 times the rate of hospitalisations for respiratory conditions, such as COPD. Those 2 green bars on the right represent 14% of the total inequalities separating Māori and non-Māori in health. Those 2 green bars alone. And I just want to say these green bars, they don't represent any genetic propensity or failure or vulnerability on the part of the patient. These green bars are our failures. And I find it really sad. These are the smoking cessation advice we didn't give, or the quit program that didn't really help, the housing referral we didn't quite make, the pulmonary rehab program that we didn't offer, the preventative self-management plans that we didn't put in place, and the information that we gave that wasn't understandable. These are our failures. And so what does that mean? That means that 1/3 of all admissions for respiratory conditions are amongst Māori. And as Api will talk to us later, the figures are just as bad, if not worse, for our Pacific whanaunga. So with these stats, that means that no longer is Māori health an optional add-on. It's not someone else's job. It's not something that just Māori providers have to deal with, or something we'll get to later. I don't want to question in any way the willingness or commitment that we in this room have, because I think that's fantastic and that's our driving force. But do we all have the skills, the training, the knowledge about what our Māori communities really need? And at the Asthma Foundation, we realised we didn't. We might have thought we did, but we didn't. And hence, we started this Māori Engagement strategy. We actually went out to provider networks, communities, Whānau Ora collectives to find out what they actually think we need. And that's really already started informing our strategic direction, as you'll see. So we really want to have much stronger collaborations with you out in the community, your provider networks, and really start tackling these issues of the quality and access to care that we have. In phase one, just very briefly to sum up what we did, we went out and met collectives. We introduced ourselves and what it is the foundation did. The damning indictment was that half of them didn't know who we were or what the foundation did. But we picked ourselves up from that, and we're continuing our collaboration and really identifying what is the gaps and what works. And as a result of that, we had 5 recommendations from phase one, that we continue to build our relationships with the Whānau Ora collectives and communities to understand their needs, that we investigate and explore innovative resources that are actually fit for purpose and of relevance to Māori communities, that we collaboratively develop a respiratory research agenda that actually is more holistic in its nature. It's not just about medication dispensing or adherence, important though they are. The providers told us it's more about the complementary methods of maintaining wellness and strategies to improve service delivery in their communities. Recommendation 4 was about best practice support structures, and I think that's an important part of what we're talking about in this presentation. And 5 was about workforce training and development. The collective said, we really need your support to get fit-for-purpose programs and initiatives to support them to maintain their standards. So in this phase, we're excited to say it's really, I feel a fraud being here presenting the strategy, because actually this is the work of the 3 collectives and some fantastic people in those groups. We aim to continue that engagement with those collectives and together develop and pilot best practice support packages. So the collectives we're talking about, we have Takiri Mai Te Ata, a group of practices here in the Hutt region, Kotahitanga in South Auckland, an area where the foundation hasn't had much presence to date, and Ngā Mataapuna Oranga, one of the very few Māori PHOs in the country in Bay of Plenty. And we took a kaupapa Māori approach, meaning that it's by Māori, for Māori, that we didn't go with a fixed agenda. The initiatives and research that came out of it was the ideas of the collectives, done by the collectives, and we were really just there in a support role. And using a participatory action research methodology. So we try something, we tweak it, we retry it, and until we can evolve it into getting it working. A critical feature was the embedded capacity, the asthma champions. We actually, a small amount of putia, but we actually were able to support a nurse identified within those practices to take on that leadership role, to champion asthma in that practice, to take a leadership role. It raised the awareness within the staff, the community. It became a locally owned initiative, and it really shortcutted it quite a bit for us in terms of gaining access and trust to those communities. So the team, the fabulous team that we had to work with, the 3 respiratory asthma champions, and for those who stay on in this room after this presentation, the stars of the show are actually going to be talking in the breakout session after this, Vicky, Marae and Lee, supported by Bernadette, who's the Foundation's liaison nurse, who really helped try and hold it together. And with each collective, fantastic support crew, including Cheryl and Dr. George Gray, Janice Cooker as our board rep. So a fantastic team. These are the 3 work streams that came out of that. Effective community engagement with Māori rangatahi, so youth with asthma. Effective communication with whānau in the healthcare context. And effective service delivery for Māori with asthma. And so these are the ideas the collectives individually came up with. And so we're going to run through each of those in turn. I want to start by work stream 1 and talk about the fact that concern there was the collective said, well, How do we know if we're doing a good job? It's very hard to know. There are no established indicators of service effectiveness for primary health. There are no nationally available comparative data for benchmarking our practice. They said our performance. How do we know? Well, you may have seen the Health Quality Safety Commission have an atlas of variation. It talks about regional differences, but these are based on secondary outcomes. This is about ASH hospitalisation, so avoidable hospitalisations. So we get a sense of where things haven't worked, but what happens in primary care remains a bit of a black box. They said we want some sort of dashboard so we can see what's working, what's not, where we should be putting our investment. A bit like this dashboard. I don't know if those of you who are in DHB land with me know that the DHBs are all listed across the top, and all our national health targets, performance measures are down the side. So you can see at a glance, without being able to see any of the numbers on there, that for most things we're doing quite good. Green means we've met target. And then all the various yellow, orange, reds are increasingly away from target. And so you could look at that and say, we're not doing bad. This is the non-Māori graph. That's the Māori graph. You can quite easily see that actually across the board we're performing less well for Māori. But we have none of this data in primary care. So that collective were really interested in assessing data quality in primary care, refining what kind of primary care indicators we use, and considering the whole patient journey. And so Dr. George Gray, who actually puts these dashboards together for all the district health boards, supported that collective. Looking at the whole patient journey is the ultimate plan, indicators in the home, primary care, community, and in the hospital. And there's a long way to go to get to that. We started with the National Institute for Health and Care Excellence standards. The UK have 11 quality statements that guide their service care. For example, each person with asthma should have a written personalised action plan. Each person with asthma should have a regular inhaler technique monitored. Each person with asthma should have an annual review and assessment of control. These 11, we have none of these yet. And there's a number of barriers in actually trying to get this kind of data out of primary care. The data that goes into the practice computer was not really collected for these sort of audit purposes and tends to be less rigorous than epidemiological survey data. We know that up to 37% of Māori patients are misclassified by ethnicity in the practice management system. And there's a big piece of work around trying to improve our ethnicity data collection in primary care. Coding of information is known to be poor. When smoking status was first done, it was only about 50% accurately coded. So it's the incentive program, the government program, that has really boosted the quality of data collection there. There are other barriers. We conducted 13 interviews with practice staff around the collective. They widely acknowledged that management was poor. It wasn't really evidence-based. Diagnosis loosely guided. No monitoring systems or alerts, recall systems were in place. Very little follow-up. Education quite limited in terms of the opportunities. Few utilising an array of resources. Action plans often not considered useful. And the bottom line was, they said, if it's not a target, we struggle to do it. You know, it's the reality. So a lot of work there. So what we actually did in this case, what the collective did, was to extract data from those 5 clinics using customised medtech queries, looking at children 0 to 14 and looking to how many actually had asthma on read codes. And comparison was made with the New Zealand Health Survey. So we, over 3,250 children, 80% Māori, and by comparison with prevalence data, only 62% of children were even coded as having asthma. So that's the first problem. How do we know we're performing for asthma if we're not actually coding it as asthma? And I know there's been a lot of concern and debate in paediatric literature about when to call things asthma. So that's the first hurdle. We then went through, looked at some of these other indicators: provision of asthma education, an asthma plan, a review, inhaler technique, peak flow monitoring. How many of these do you think were coded in the practice management computer? Of the 3,500 children, there were less than 5 episodes of each of those. So we have a real data quality issue there. It's quite incomplete, and up to 38% of Māori asthmatic children may not have even been coded with a diagnosis of asthma. So there's a whole bunch of recommendations that obviously flow from that around better diagnostic criteria, stressing the importance of coding, monitoring, and before we can get to having really good indicators, I think we're going to have to get a lot more robust around that.
Kia ora anō. Under work stream 2, I will focus on effective communication with whānau in a healthcare context and the development of culturally appropriate asthma resources. So as a collective, it was decided that there were communication problems, and Tristram's alluded to that, occurring between whānau and health professionals. This was a priority for us to try and address this issue. It was decided that the development of resources that were culturally appropriate, targeted toward teenagers, and strengths-based was a priority for our collectives. Te hautapu o tāwhiri mātia. So we looked at developing a toolkit comprising a set of talk cards to be used by kaimahi or health workers with key asthma messages to enable some consistency across our 3 Whānau Ora collectives. We needed input and buy-in from our community, so we held a focus group with rangatahi, teenagers and some of their parents. And I'll talk a little bit more about our focus group in a later slide. It became evident that the talk cards alone were not a useful tool for whānau. Whānau clearly indicated that they would like to see a visual educational resource and talk cards that gave them strategies when communicating with schools, sports coaches, health providers, friends. Hence, we decided to seek additional funding to develop a DVD to complement the talk cards. And just with regards to the focus group, there's nothing like holding a community focus group to truly ground you. We thought we had all the answers when we went there. So we developed the talk cards around 9 key areas identified by the whānau in the focus group as being important to the well-being of their teenagers and whānau. We utilised some key Māori principles, and it was jointly decided that we focus on tautoko hononga, which is how does a friend support, manaakitanga, hapori, hauora, how does the health organisation, caregiver support, oranga whare, acknowledging healthy housing, kaitiakitanga, whānau, guiding and caring for others, wānanga kura, how can the school support, tūpuna whakapapa, connecting us to our past, present and future, rangatiratanga, self-management, manakai whakaako is how does the sports coach support, and tikanga tākuta, support from the doctor. So here we have an example of one of the cards, and if we look at the first slide, mana, on one side we have the key principle. For this card, mana, this card is could be talking about the child or the whānau member's status in the community as a member of a sports team, their prestige, their influence, because we see them as role models. So, really encouraging messages. We tried to keep it very strengths-based. And because whānau had told us that they wanted us to give them some tools so that they could go out and talk to the sports coach or the schools, we put some of the encouraging messages, I suppose, we put on here is: how does your club support rangatahi and tamariki to manage their asthma? How confident are your coaches in managing a child with asthma? Who are the providers in your area that can support your club to get educated about asthma? We tried to encourage the clubs and coaches to be more proactive and whānau to feel confident about asking the questions and to jointly look for solutions. Whānau were really clear in the focus group that everyone in the community had a role to play in keeping their child well. So we decided to develop a resource that had interlocking pieces to show that with everyone's contribution, a whānau ora approach, there was more chance of being successful. So this is how it looks when it comes together, showing that everybody, there's a part there for the teacher, there's a part there for the doctor, for the health worker, etc. So everybody plays an important role. Then we come to the visual resource. We had an amazing turnout of whānau who wanted to support the development of this resource. They were really clear with us about the information they would find useful. For example, how can their sports coach be well informed? How can they approach the school? We decided to develop the DVD around the concept it takes a village to raise a child. The parents in rangatahi wanted a resource that Māori could relate to. We decided that it was important to ensure that a te ao Māori feel throughout the short film was evident. Rangatahi were interested in pūrākau, the Māori stories of our atua Māori gods. We decided to include the Māori creation story of Rangi and Papa. They were clear it needed to be real, and it was felt the issues were different for boys and girls. So sport of choice for the boys in the focus group was boxing, rugby league. For the girls, hip-hop, dancing and netball. So really quite different views. Hence we decided to develop a separate resource for teenage boys, and we're looking for funding to develop another resource for the girls. We were really fortunate to have the expertise of local community people to help contribute to the production of this resource. In total, 47 people from our community participated in the production of this DVD. We used local Māori talent for the filming, so we didn't have any actors. All these people are people who came to our focus groups, people who heard about the filming and wanted to come and contribute. 2 young Māori film directors who had developed a DVD earlier a couple of years ago for our Māori provider and had won a Māori Film Award, asked to be able to film this resource. We had another 2 local Māori women who developed the concept, the storyline, the waiata that you'll hear in here, and the talk cards. And a young Māori mum that we've worked with, her 2 children with asthma, asked if she could design the artwork.
So we thought we'd take the bold move of actually showing you the resource with your indulgence. If we could now play that, and we may need to dim the lights.
Yeah. So this is the community's DVD, Te Hautapu o Tāwhiri Mātia.
Whakataka te hau ki te uru, whakataka te hau ki te tonga, kia mā kinakina ki uta, kia mā taratara ki tai, e hi ake ana te ata kura, he tio, he huka, he hauhu, ti hei Māori Ora. Kia ora, that's me, Tāwhiri, te hautapu o Tāwhiri Mātea, or just T. Yeah, that handsome fella with the mean kit? Far, look good. I'm pretty much a professional boxer. Now you're straight up. I've got like 31 wins, all by knockout. But nah, I haven't been boxing for long. Tonight is actually my first big match, and everyone is here. So I've been working hard. I love to work hard. My boxing coach Sam, yeah, he's been helping me heaps with that recently. He's mean. I've had to learn how to manage my condition. So every morning, before I begin my day and train, I take my rongoa. I have a story to tell about my condition. You see, I have asthma. Taku pūrākau tapu, from Tāwhiri Mātea. Te hautapu o Tāwhiri Mātea. That's me. I learned that from my koro. He gave me my flash name because I was born the day after a massive storm here in Te Whanganui Atara. Koro said the wind was light and gentle. You reckon on days like that, Tāwhiri Mātea, the atua of the wind, carries sacred stories to special people. Koro told me when I was a young fella, I used to get sick heaps. Koro said that Tāwhiri Mātea, he gave me lungs with sensitive airways that may tighten up, swell inside, and make mucus that made it hard for me to breathe. There was one night when I had trouble breathing, and that him and mum didn't know what to do. They had to call for help. I don't remember much, but it was really serious. Koro said he'd never been so worried. The nurse had to give me a nebulizer. Mum and Koro, they really listened to what the nurse had to say. They got clued up on conditions like bronchiolitis and asthma, te mo te huango. She told them which rongo to take for my condition, especially the orange one. That's my preventer. She also referred us to a community asthma nurse from Kokiri Marae, and that she would come to our whare for a visit. Nurse Mere showed us heaps of cool little tips to help make our whare healthy. He kāinga oranga. She gave me a treasure box for my rongoa and management plan to be in. She even taught us a choice little waiata so I could remember how to use my spacer properly. Me, Koro, and Mum never forgot that waiata. My asthma, it never stopped me from doing things. Koro used to take me outdoors and we used to get up to all sorts of choice stuff. I remember this pūrākau Koro told me about Tauranga and Tāwhiri Mātea. Kauri a Tāwhiri Mātea I whakai ki te wehenga o Ngā Mātua. Tāwhiri didn't want his parents separated, but Tāne Mahuta separated them anyway. So Tāwhiri set out to seek utu on his brothers. Tauranga also turned on his brothers. Tauranga attacked each brother and removed their tapu by eating their tamariki. And because Tāwhiri Mātea went to live in the sky with rangi nui, two couldn't reach him. So Tāwhiri attacked each of his brothers. He went handi, but two withstood each attack. Here's the atua of humankind. Tāwhiri vowed that he would continue to attack Tauranga me ona tamariki. Koro said Tāwhiri would send massive storms to try and wipe out two's children. He reckons that Tāwhiri also attacks tū mā Tauranga by giving us tamariki, asthma and other breathing conditions. So koro anai, we made up our own cool hand signal to remind me to be strong and that we got each other's back. I love my koro. He's the man. Tama's been my best mate for ages. He's a good fella and always had my back. I remember this one time we were outside running around in the bush. It was a mean time. But then I got too excited and started losing my breath. It got heavy and hard. I tried to pretend I was okay, but Tama knew. He knew that the blue inhaler, the reliever, helped open my airway, and the orange one, the preventer, helped to prevent attacks from Takiri Mai Te Ata. I wasn't very good at managing my asthma symptoms, and I would always think I was sweet, when really, I wasn't. I'm glad I had Tama's tautoko. Koro always said I was lucky to have a mate like Tama. I should have been taking my preventer morning and night. Engari, te nuinga o te wā, I wareware ahau ki te mahi. I would always forget. Koro was good at taking care of me. He helped me understand the effects of my asthma. Koro says my asthma is just like the weather. Ngā tohu o tāwhiri māteo. Unpredictable and sometimes hard-hitting. And Mum made sure I knew that. So I had to learn how to take care of myself. We decided to help everyone in my life understand my asthma. Like my teacher, Matuarangi. He was cool, so we rang Kōkiri Marae and asked Nurse Marama to come to the class. We showed him how my breathing is different from people with healthy lungs. And how to use the spacer. Then the whole kura knew what to do and where my rongoa was kept at school. Koro always knew my condition would be one of the biggest challenges in my life, but to never be held back by it. I won't let my asthma stop me from doing what I want to. And I've learned that I have to work at keeping myself well. So, here I am, te hautapu o Tāwhiri Mai Te Ata. With the Māori of my tupuna within me, and the support of my family, friends, and community, I'm here and I'm ready. To my nurses and coach, thank you for putting in the hard yards. I'll never forget them. Thank you, Matuarangi. Thank you, Mum, for raising a beautiful child like me. Thank you, Tama, for always being there for me. And thank you, Koro. This one's for you. E hara taku toa I te toa taki tahi, e nari he toa taki tini.
Ko te mahi he tika o Tauranga e, whakarongo mai rā e. Weri weri Tauranga a whakauru e.
Kia ora. So, as you see, different, quite different, and you know that's what you get when you actually put the community in charge of coming up with a resource. You don't always get what you expect, and I think that's fabulous, because we've had some fantastic evaluations from it. We've just started evaluating, but we've had a range of people, and overwhelmingly positive reactions to it. Really good feedback about it being innovative, well made, and more importantly, the people the whānau that have seen it have said that it significantly improved their confidence in managing their own asthma and where to get support, and also it's improved their confidence in actually talking to health professionals about asthma. There's a range of different themes running through it, between the asthma health information, the medication, lifestyles, role models. We asked whether people thought we'd got the balance right, and actually that was what they wanted to see. So some fantastic feedback there, and we're going to continue evaluating it across the other 2 Whānau Ora collectives in months to come. In the interest of time, we'll skip work stream 3 because the staff will talk about that in the next session as well, the Breathe Easy competition, and some of the fantastic components that we had there. But to summarise, the theme of this conference is stepping stones, and this talk, stepping up for Māori. And so, like the potama, the stairway up, the foundation have made a bold commitment to try and improve our game, improve our responsiveness to Māori. And I think all 3 of these work streams showed that you give a little bit of resource, a little bit of encouragement to community providers. There's a wealth of talent and resource in there, and some really innovative ideas and initiatives. And as the champions will tell you in the breakout session, some fantastic ideas have come from it. So I guess it's our challenge, our taki to you and your organisations as well, is to step up for Māori. Kia ora.
Kia ora.
Thank you very much. A most fascinating session and a wonderful video. Excellent. And that's going to be continuing in the next session. So I think
Yes.
we're a little bit over time. We're just I think we'll just leave it at that point and invite first of all those people who would like to. We now have 3 concurrent sessions. So the panel discussion here will continue with further discussion about engaging with Māori and so forth. In the Featherston room. Thank you. You're right. Okay. Very good. Let me just. I'm ahead of myself, so we'll have a thank you first of all. Thank you very much. Please. Let's have the. Thanks, Teresa.
Kia ora kōrua, mō te kōrero. It's a bit like the kumara, talking about the kumara, because I'm part of it, so you don't understand if you're Māori. But I'd just like to say, often we're quite burdened down by a lot of the statistics and bad news that keeps coming at us all the time. And I think it's heartening to see there's a light for us as a people. And for me, light is about knowledge and skills and self-management, and that tino rangatiratanga over us, that informed practice and knowledge, and people like you two who work for us in the sector. So kia ora kōrua, and thank you for your contribution and your health strategy. Kia ora.